Good morning, good morning. Hear me okay?
Yes.
Very happy Saturday to you all. My name is Helen Wong. And, okay, let me see. Shall we start now? Okay, and for the time being, we'll just wait for the others to come along. Okay? One important announcement first. There is water dispenser just outside. And then there's also cups there. At any time when you feel thirsty, please help yourself, okay? Just outside. Alright. Now, okay, this is my partner here, Gao Min. She's a nurse in the hematology department. She will translate in Mandarin because I can't speak Mandarin. Okay. Then,
大家好，大家早上好欢迎大家出席今天的骨髓瘤论坛。感谢大家的出席，感谢大家腾出宝贵的时间和我们在这里愿大家有美好的早上。刚才海伦有说因为外面水在外面，大家如果觉得口渴，可以到外面去拿。
Today is the 5th forum. So the forum we hold is every year. Then every quarter we do have meetings. For those who don't know, every quarterly we have meetings. Sometimes we do it alternately, SGH Hospital and NUH. We will contact you. That's why we ask for your contact numbers and email. All right. Now we are family. I'm also a multi myeloma survivor for 8 years. And now it's still going strong. Thank you. But Gao Min here is a nurse from the hematology department. Okay, now today we have a list of talks by Dr. Sathish. And just to let you all know, apologies from Prof. Chen. He's unable to come today because he is probably on the plane right now. There's some flight delay, so he will not be able to join us. In place, Dr. Sathish will give 2 talks. All right, one on transplant and one the latest update on myeloma. And we also have senior psychologist, Dr. Joanne Chua from NUH to give us a talk to some sharing and a patient sharing, and then we have a music performance, and after that we'll enjoy some lunch. Okay?
站在我身边的这位是海伦，她也是骨髓瘤的患者。你看她现在这么年轻，这么漂亮，就知道她过得很好。我之前是一名护士，现在在血液科，现在是在做骨髓移植的联络工作，所以我今天会以华语来为大家主持。
Okay, now.
这个是我们第5年的骨髓瘤论坛。所以今天我们有 Dr. Sathish 还有 Dr. Joanne Chua 给我们做讲座。接下来还会有病人的分享，还有音乐的表演，最后将是我们美好的午餐时间。
Okay, now shall we put our hands together and welcome Dr. Sathish for opening talk.
This is an informal thing, and it's been running for 5 years. So
if I make some assumptions that we know a little bit about myeloma, but that's why the game has slightly changed. So we've gone to slightly more advanced discussion about new drugs and things like that. The first few years we concentrated more on what is myeloma, etc. But that doesn't stop you from asking questions, and there is plenty of time to do. So don't feel that this is not the place. This is the place. And in fact, I have how many here who can translate Mandarin. So if Helen cannot do it, then surely I cannot do it. Before I start talking, I just want to tell you two things. First of all, in the new era, in the last 10-15 years, information has become widely more available, and patients can access data on internet very easily. So this brings responsibilities and challenges, and also good to the patients. So the good thing is that anybody can go and look up what's a good drug, etc., etc. But it also brings up a lot of information that sometimes can be difficult to handle. But one good thing is that I think it's important that patients have the right to know, and that's the main thing. I think patients should have the right to know and to make an informed decision. And in fact, it was I don't know whether you watched this movie called Decoding Annie Parker. It was released last year, and this is a story about a breast cancer survivor called Annie Parker. So she was diagnosed with breast cancer, and she had a 3 family generations. So her mother, grandmother, her sister all died of breast cancer, and she couldn't figure out what was going on. So she was one driving force behind doctors to pester them to find out what's going on. And finally, a BRCA mutation was found out, and one of the doctors was closely related to her work. So sometimes patients can also bring genuine changes to a new medication. So I think always ask questions, and in real life this being said, if you have some questions, ask questions, and if you're not clear, ask more, ask for more time. On the same topic, I want to tell you that we have now a new myeloma booklet, which is 37 page. Which is now being printed both in English and Mandarin. And if you give your names today to us, we can make sure that it will be sent out to you by post. I want to get it out today, but we could not do it in time. But it's more updated than the one that was brought up before. But it also has information on the website that we have both here and in UH. And also international websites that have information on myeloma. So all this is done with the hope that you have more information in your hands to make decisions. So with that, I think we'll start talking. So we'll talk a little bit about bone marrow transplantation in myeloma, and the reason why I wanted to bring it up is because we talk of transplantation and it means a lot to different patients. For some people it means operation, some people it means a major thing which is related to death, etc., etc. So I wanted to tell you about my perspective and what we have seen in Singapore, so that it gives some comfort to patients and also some reassurance and also an opportunity to ask questions. So if you feel there is an issue, you can stop then and there. This is not, this is a bilateral discussion. It's not there, I keep on talking and you keep on listening. Here we have the history of development of myeloma drugs. So if you see, the first case of myeloma was seen in 1844. It was as long as that. And then you will find that for the longest time, up until 1940s, we didn't have good treatment, and slowly, things started to change. Yes, so you can see that melphalan was one earliest drug that was discovered, and after that we had steroids coming along, and then transplantation, autologous, that is what we do now, was found out in 1970s, in the 80s, but it didn't gather momentum for many years to come because of a lack of acceptance from doctors. And that the real changes happened in the 90s when you had thalidomide and bortezomib, which is Velcade. came to existence, and after that lenalidomide in 2002. But following that, we had at least 3 drugs coming up, which we will talk about in the next session, which are pomalidomide, carfilzomib, and panodenostat. So these are the 3 new drugs that are now FDA approved for myeloma. So it has been around for a while, and we know that we got 30-40 years worth of data to support what transplantation does in myeloma. So this is just a slide that I pulled up, and what it shows is that this is the top is the graph that shows people who have undergone transplant, and the bottom is red line is for people who have not undergone transplant. And this is survival. Survival means duration from the time of diagnosis of myeloma to the time of death. And what we find here is that there's significant difference in the beginning, but as you see later on, we see that people who had transplant had myeloma coming back. So what it does is that it can give you a good mileage in the first few years, because if you don't have transplant, you see that people tend to have myeloma coming back and succumb to the disease very early on. But if you have transplant, you see that there are more people alive for the first few years, and later on it comes back. So this shows the strength and benefit of transplant, and also the disadvantage. The strength is that more people are alive in the beginning, but the disadvantage is that it's not a cure. People do relapse with myeloma after a few years. So transplantation is only good as a good treatment, but there is no guarantee that myeloma will not come back. That's the main message. But the good thing is that maybe this is what is needed after all, because what we have now is a lot of good drugs coming out. So we do transplant and we gain a few years out of it, and then we have new things coming out at the back of that, which will continue to prolong their survival. This is improvement in survival over years in US, not in Singapore. So this is across different races: blacks, whites, Asians, Hispanics. Over 5 years, they found that when we look at a number of people, we're looking at people with going to very good hospital, people going to very bad hospital. So it's a mix-up of patients, and you see that over the time. 34 to 45, it doesn't seem not much when you look at numbers, but in reality it means a lot to patients. And when we look at our own survival Singapore data, you see that before 2008, the 5-year survival was 38.5. These are for people who undergo transplant. And now after 2008, it's 50%. So we've had the same kind of improvement that has been shown in the world, rest of the world in the US. And we decided to choose 2008 was because after 2008 was when Velcade became widely available in Singapore and was started using. So novel drugs like Velcade and lenalidomide have made a big impact on the NAB. Now what we are aiming for is to improve it further. Okay, so it's not, to me it's a good thing and it's reassuring. And I think if you look at all patients, we see that in 10 years we only have 20% people alive. So that is a sad truth. So that's what we are trying to improve, okay, with myeloma. So, although overall, if you look at all patients, we still have a good number of patients, alive in 5 years. We see that most patients have myeloma coming back, and that is where, we are trying to improve things. And I also want to tell you that, although we've been internationally very active, it's for the first time in this year, 2014, that we were successful in opening our own clinical studies. So we have now 2 studies in myeloma, all originated in Singapore, and one of them is for people who are newly diagnosed with myeloma. The other one is for people who have relapsed myeloma. So the relapsed myeloma patients are eligible to get pomalidomide, which is a new drug, an FDA-approved drug, and for newly diagnosed patients, they can get carfilzomib as part of treatment. They have been FDA-approved, which means that they are safe drugs, and we are happy to have them. And it also gives us an opportunity to be bringing these drugs to patients. They are not available off prescription in Singapore right now. They can't be bought if you want to get it right now. Maybe later this year they'll be available, but they are not easily available right now. So we are trying to improve on these things that we already got, and I'm hoping that in the next 5 years we'll see this graph getting even better. So, this is one statement that is underpinning all the activity that we do, that transplantation is the gold standard as of now. And there is no two arguments about it. So we'll go into the nitty-gritty of it, and it's just a few slides on, in simple terms, what it means. So it's not an operation, okay, and we don't need donor stem cells in most cases. So the common type of transplantation we do is the one where you get your own stem cells, and the second type is where you get stem cells from somebody else, and we don't do it generally for myeloma, at least in the beginning, because the side effects are a lot higher with that kind of transplant. So how do we decide who has to have transplant? There's a discussion between, so every hospital has a team of transplant doctors. So we kind of meet up every Friday and discuss all the patients that we have who may be considered eligible for transplant. And we discuss all patients in detail, and the decisions are not made by one person, but has to be agreed by a number of people. And that's the standard process anywhere in the world. And the age is a shifting target. We know that we have a much fitter patients who are in 70s, and so age in itself is not really what matters. It's about the physical fitness that matters. So and also the preparedness of the patient. So even if you're 50, if you're not prepared for transplant, then it's a non-starter. But if you're 65 and motivated, or 70 and motivated, then that is what we want. We need to have a supportive family from the patient side, because it's not a single man's business or a single person's business, and it needs a whole support from the family. We also do tests of heart, kidney, and lung to make sure that they are safe and are able to tolerate transplant. So the first step is, we have to bring down the myeloma to a good level first before we think of transplant. Transplant doesn't work straight away at time of diagnosis. So in the beginning, we have to give a few cycles of chemotherapy to bring down the load of myeloma. And once we achieve that, the first step is stem cell collection. And what we do mostly in Singapore and probably around the world too is to give a small amount of chemotherapy with a booster injection to mobilize stem cells into the blood. It takes about 2 to 3 weeks stay in hospital, the expected side effects are, some patients end up getting a central line. What it means is that it's a plastic thing in your body. It's kept for about 2 to 3 weeks because to collect stem cells from your body, we need blood to flow very quickly and without stopping. And if you put a small plug in your arm, it doesn't flow very well. So the blood comes out, goes into the machine, and the stem cells are removed, and the blood goes back into the other one. And this process can take up to 2 to 3 days, every day about 6 hours. Once the thing is done, it will be taken out. But this is something that some patients need. If they have very good veins in the arm, they might be able to do with that. But if you don't have good veins, then we'll have to have this one in. There's risk of infection because we do give chemotherapy to mobilize stem cells. There may be some hair loss because of the chemotherapy that we give too. We aim for a 2.5 million stem cells. This is a minimum that we need to do a safe transplant. Okay. If you use more number, like 5 or 10 million, we can have a faster recovery. In some patients, we might do storage of stem cell to do a second transplant. So that is, something that we decide between the patient and us. Typically, if you are, not in your 70s, if you're only planning for one transplant because your age is in the borderline anyway, we wouldn't collect for 2 transplants. But if you are, somebody who can benefit from a second transplant, we might collect stem cell. So about second transplant, there were still some studies which were published last week, which shows that a second transplant is better than chemotherapy when the myeloma comes back. But this is not a well-conducted study. But I'm just saying that second transplant is still not a bad option if the first transplant went well. And we got at least 2-3 years from the first transplant. So if the first transplant failed straight away, with the myeloma coming back within 6 months to 1 year, the same kind of transplant will not work. But if you got a good 2-3 years from the first transplant, and if you are still fit to get a second transplant, we should try, if there are stem cells available. Because once you do a stem cell transplant, it's very hard to collect stem cell from that person for the first 4 or 5 years at least. So unless we have stored stem cell, we may not be able to do a second transplant straight away. We had a patient recently who had transplant 10 years ago, and we didn't have stem cells collected. Myeloma came back, and we tried a collection and it was successful. So he's collected earlier than expected. So sometimes people are. So I think that probably the first 4 or 5 years after the first one, we may not get in a stem cell, but later on, as the body recovers, we might be able to get in a stem cell from the body. So the second step is where you give the chemotherapy back. It's called melphalan. Good old drug, hasn't been replaced in the last many years, 30, 40 years. It's given, again, you'll be admitted. The same thing in your neck has to be placed, the catheter that was mentioned earlier. We give the chemotherapy for a day or two. Then we give a small rest period, and the stem cells are infused, which were collected before and frozen in the fridge. They are given back after 24 to 48 hours. And you stay in hospital for about 4 weeks after that. The risk is higher of infection, and surely there will be loss of hair. Okay, patients are unable to eat. They have diarrhea in most cases because the chemo inflames the lining of the gut, right from the mouth to the backside, and because of that, there's no absorption. So water can, there will be constant sort of watery diarrhea. Whatever we do to bring it to stop, nothing happens because it's not like a diarrhea that's caused by other reasons. So we can give pills, but the diarrhea doesn't really improve. But it improves when the counts start to recover and you're coming out of the effective transplant. The other thing is that what we call mucositis, which is inflammation of the lining of the gut, happens, and you can have throat pain, tummy pain, etc. Risk of infection is there, and there's a risk of death also, which is about 3%, mostly because of infection. And this is our own data from Singapore also. So we've done, when we looked at our own data, the risk of mortality is about 2 to 3%. And this is what you would see if you go anywhere else where transplant is done quite a lot. So upon discharge, regular follow-up, take medicines to prevent infection, and vaccination against flu and chest infection will be done also. So after treatment, so the thing is that with myeloma, treatment is ongoing and transplant is not an endpoint. Okay? So when you do transplant, most patients have a lot of hardship during that 1 month of transplant, and you think that do I have to have continued treatment after this because I have a lot of treatment now. So unfortunately, most patients have myeloma coming back, and the treatment has to be ongoing. So transplant is not curative, and you should not feel disappointed that transplant could not fix it because it doesn't fix it in most patients. So, but the good thing is that transplant can work to bring it down to a very low level, and we want to keep it at that level. Okay, so if the myeloma is in a low level, it's as good as not being there functionally, because there are many conditions where we cannot completely clear it, but it doesn't harm your quality of life and functional status. So if you can get there, that's also fine. So what we aim for in myeloma is to keep it in a low level sometimes so that you can function normally. So the next question is, when is the best time to transplant? The answer is when it comes to the first time, because this is a graph of how myeloma progresses in anybody most of the times. There is a phase of what we call smoldering or MGUS myeloma, where myeloma is silent for many years. The cells are there, the cancer cells are there, and the incidence of MGUS is about 5% in people above 60, and it keeps on going up slowly. But of that 5%, only less than 20-30% will ever become myeloma. Most people will live and die never knowing that they had this thing. So what we're aiming to do is by doing transplant to bring you back to that kind of state of MGUS, where it's there but it's not harming you. Yes. So when you get myeloma, you give treatment, it goes down, comes up. Every time it does this, the cancer cells get more and more powerful. And if you have a good treatment, it has to be given at the right time. If you do a good treatment at the wrong time, it's wrong treatment. So if you're planning for having transplant, it should be done as early as possible, rather than later, because once the myeloma comes back, the benefit you get from transplant is going to be lower. Okay? So it's always better when you do it in the beginning. So I think the key points is that it's not curable, but it will improve your survival. It will also improve the time between you having treatment and the myeloma coming back. most people for the first 3 months feel under the weather because they have tiredness, they cannot eat, they are losing, they're probably gaining weight but very slowly, have to come to hospital very often. But after 3 to 6 months, most people can go back to work if they want to. Okay, so unless they have myeloma relapsing quite significantly. So it's you have to think of that kind of time frame when you go for transplant. We're not looking at just 1 month. We're looking at 3 to 4 months from the time of transplant for you to be off work and you to be coming to hospital. So you need to have that kind of expectation when you go for transplant. And finally, it's a safe procedure, and it's even in the era of new good drugs we have, it's a good treatment. And it's still cost effective because if you look at the cost of new drugs, they are not cheap. So, for example, lenalidomide is used to be $10,000 a month, and now they've brought down the cost. And carfilzomib is about $20,000 US a month. So, if you're planning on that, you only need 2 cycles. A transplant is a lot cheaper. So, it's more cost effective, and it's something you can do locally. So, I think, and you've got 30 years or 40 years of studies to support it. So, I think transplant is still a good treatment, and I would, at least for the time being, argue for it. Now, we are doing some studies where some patients who are very, very clear of myeloma by using very special tests, if they are negative, we are thinking of not doing transplant. But that is really a study. We don't have evidence to prove that. But my hypothesis, my theory is that if you are clear of myeloma with very special tests where you can't even see it among 1 million normal cells, there's not even 1 cancer cell, maybe they don't need transplant. We just keep the myeloma, transplant for them when it comes back later. So that's the theory that we are testing. So in the next 6 months to 1 year, we'll have a new study coming for that, where people who have no evidence of myeloma in the beginning, we just collect the stem cells and we still freeze them. We don't do transplant. But this is only for people who are showing no signs of myeloma using very special tests which we are not currently doing. That's part of the study. But that's maybe in the time to come, we may have some number of people, not many, I would say probably 10 to 15% of people who may not have myeloma after good treatment. But we don't know how to predict them for now because we don't have such good tests. So I think in the next 10 years we should have strong technology, good technology, which can tell us patients who don't need transplant. That's the hope. So with that, I will stop my first bit. Maybe Carmen, you want to talk? Huh?